Hello, my name is Dr. Dilip Nair. I am an epilepsy specialist here at the Cleveland Clinic Neurological Institute Epilepsy Center. This presentation will be a discussion of the use of intracranial monitoring in patients who are undergoing epilepsy surgery using subdural grids and strip electrodes. In the presentation, we'll be talking about the historical aspects of this procedure. We'll be talking about also indications and limitations of subdural grids. We'll discuss a specific case and then go into some research applications using subdural grids. Subdural grids are placed over the surface of the cerebral cortex. They are able to record intracranial EEG activity, which is also called electrocorticography, that arises from restricted regions of the cortex that would otherwise be blind to scalp EEG electrodes. It allows for sampling contiguous areas, which can be helpful in delineating the boundaries of abnormal epileptic activity and the adjacent regions of cortex that support normal function. It can be performed either acutely in the intraoperative setting or chronically over several days in a video EEG monitoring unit. Wilder Penfield and Herbert Jasper were the first to use subdural grids in the late 1930s and early 1940s. Fisher Williams and Cooper in the 1960s were able to show their effective use of recording hidden regions of the brain such as the orbitofrontal cortex, amygdala, and hippocampus. They became in routine use in the mid-1970s for the evaluation of epilepsy surgery. Currently, amongst various institutions, there is quite a lot of variability in the indications, techniques, whether a decision of using it in combination with depth electrodes, as well as other aspects such as the number of electrodes and regions of cortex that are typically sampled. Also, more recently, within the last decade, there's been an increased preference of the methodology using SEEG, or stereo EEG. This will be discussed briefly in this presentation as well. The generators for electrocorticography, or intracranial EEG, arises from intracellular laminar currents of the apical pyramidal cell dendrites in the outer layer of the cerebral cortex. These currents generate electrical dipoles, and these sheets of dipoles arising from excitatory or inhibitory postsynaptic potentials make up the generator source for intracranial EEG as well as scalp EEG. The activity can be recorded from a distance as a result of the linear summation of the unit dipoles when the population of neurons are more or less synchronously activated for a sufficient period of time. Volume conduction of these electrical currents can occur from a generator that spreads through the volume conducted media and picked up from a remote recording electrode, giving a false sense of location of the generator of that particular electrical source. There are a number of limitations of scalp EEG, which forms the basis for why subdural electrodes are used. Scalp EEG waveforms are mostly influenced by dipoles at the apex of the gyrus, as they lay perpendicular to the scalp and create vertical dipoles that are visible to the scalp electrode. Only sources that extend over multiple cortical layers that comprise several square centimeters will have sufficient energy to generate the detectable discharges from the scalp electrode. Approximately 70% of the cortical surface lies within the depth of the sulci, and also many brain areas, including medial surfaces and other deep structures, are not optimally recorded by the scalp EEG. Epileptiform activity from deeper sources may appear so small in amplitude at the scalp electrode that it may be obscured by background activity and thus be invisible to the electrode. Passage through multiple layers, CSF, dura, skull, and scalp, causes a smearing effect on the surface potential distribution, causing the potential from localized foci to appear in a much wider scalp area. There are advantages in using subdural electrodes over scalp EEG. Most of the artifacts seen in scalp EEG are not present in subdural recordings or are present at much lower amplitudes, yielding a much better signal-to-noise ratio. Subdural recordings are also less sensitive to the orientation of the dipoles generators than is the scalp EEG. Spikes or sharp waves are recorded by the scalp EEG only when a relatively large area of cortex, somewhere between 6 to 10 centimeters squared or larger, have been involved in epileptic activity. The use of subdural electrode recordings provides the opportunity to detect focal EEG seizures well by decreasing the distance between the recording electrodes to the cortical surface. Subdural electrodes can provide a wide coverage over various surfaces of the cortex with contiguously spaced electrodes. There are two main types of subdural electrodes, strips and grids. Strips are basically a single array, such as shown here, a 1x6 array, whereas grids comprise a larger coverage, and in this example it's showing a 10x12 subdural grid. The standard dimensions of the subdural electrodes is 0.27 millimeters thick with a diameter approximately of 3.97 millimeters and a center-to-center inter-electrode distance of 1 centimeter. This is the typical dimensions of a subdural grid that's used in our institution, but they can vary based on manufacturing. The surgical placement of the electrodes require general anesthesia and performed in the operating room. The insertion of the subdural electrodes can be accomplished by using burr holes, whereas subdural electrodes require a larger craniotomy. Most of the subdural grids are placed under direct visualization to avoid bridging veins, bleeding, or other bony malformations, whereas smaller grids or strips can be slid under brain surface without direct visualization. Subdural electrodes are typically left implanted for a period of 5 to 10 days to allow for more chronic monitoring of epileptic activity and mapping eloquent regions of cortex. Here's an example of an intraoperative picture showing the implantation of several subdural grids in a patient who has suffered medically intractable focal epilepsy. Shown in the photograph is a depiction of a proposed MRI lesion that might be associated with the patient's epilepsy, and the orientation of how the electrodes are placed, showing the midline, the temporal lobe, and anterior aspects of the surgical craniotomy. On the right-hand part of the screen, you see the skull X-ray that was obtained postoperatively, delineating the 4 subdural electrodes pairs named SA, SB, SC, and SD. Next, we'll talk about the postoperative care and imaging for localization of the subdural electrodes. Recordings of electrocorticography are usually performed in a less restrictive environment, such as a hospital room or epilepsy monitoring unit. The ability to understand the exact location of each electrode over the cerebral cortex must be established with considerable accuracy, so that we can obtain an accurate location of the anatomical mapping of both the epileptogenic lesion and the eloquent cortex. The pre-implantation MRI scan is often used to co-register the electrodes using postoperative implantation images of either CT or MRI scan. Following the insertion and localization of the subdural electrodes, the initial phase of the evaluation involves localizing the irritative and ictal onset zones. These two zones are important in the definition of what is considered the epileptogenic zone. This definition, when using subdural grids, is defined as the region of cortex which, when resected, will result in a patient being seizure-free postoperatively. The location of the epileptogenic zone is estimated to reside within an area defined by the concordance of findings from a variety of investigations. These, importantly, include non-invasive evaluation prior to the subdural electrode recordings. This is the example of the interictal findings in our patient shown on a bipolar montage. As you can see, highlighted in yellow are regions of epileptic activity in the form of repetitive spikes seen on the SB electrode grid shown in the figure. Highlighted in yellow on the figure are the electrodes that are primarily involved in this epileptiform activity. Here is the same page shown in a referential montage, more clearly delineating the electrodes of maximal involvement in the repetitive spike discharge. you can see highlighted in red, electrodes SB35 and SB39 are primarily responsible for the generation of these interictal spikes. On the 3D rendered image of the brain is the location of the two electrodes in the yellow circle, which you can note is adjacent to the proposed MRI lesion that's shaded in green. Here is the sample of the ictal abnormalities seen in the same patient. In the beginning of the page, you can see the interictal epileptiform discharges occurring in a very repetitive sequence. At this moment, highlighted in yellow with the triangular bars, is the area of ictal transition, in which a very large spike is seen primarily in the same electrodes showing the epileptiform interictal abnormality, following which there is a transition to faster activity that is seen propagating in the same areas along with spreading in adjacent regions shown in the open red triangles. Here is the same ictal transition shown in a reference, and now we can clearly see that the areas of primary involvement of ictal transition are the same electrodes that showed the repetitive spike discharge at SB35 and SB39, again shown here on the 3D surface rendered image is colored blocks of red with a shaded area of red showing the area of the propagation of ictal transformation. A key aspect in the success of subdural grid electrode mapping is a hypothesis-generated grid placement strategy. Here, a clear notion of where the epileptogenic regions within a particular patient have to be assessed prior to the placement of the subdural electrodes. Therefore, patients undergoing epilepsy surgery, a clear hypothesis about location of the epileptogenic zone and other areas such as functional eloquent cortex can only be obtained after a successful hypothesis has been generated from all the non-invasive evaluations prior to the grid evaluation. Challenges in the interpretation of intracranial EEG findings occur when the invasive evaluation is begun without a clear hypothesis. In cases where the hypothesis was not well formulated, the ictal patterns can be either diffuse or be seen in the margins of the grid, with this resulting in the required removal of the electrodes without any clear plan for epilepsy resection. There are important differences to be noted when comparing the use of depth electrodes as compared to subdural electrodes. Subdural electrodes are mainly implanted over the dorsolateral frontoparietal convexity, basal neocortex, mesial neocortex, and interhemispheric neocortex. Initially, the use of subdural electrodes paired with depth electrodes were placed with a freehand approach, mainly targeting the mesial temporal structures. Currently, depth electrodes are guided by an anatomo-electroclinical correlation methodology using stereo navigation, also known as SEEG. This is now becoming an increasingly preferred choice of the intracranial EEG evaluation in the United States. A decision whether to use subdural electrodes or depth electrodes, including SEEG, is mostly determined by a number of factors. They include the degree of concordance of non-invasive data, suspected pathology, aspects of the seizure semiology, the need for functional brain mapping, and specific aspects of the hypothesis location of the epileptogenic zone. Here we'll talk about two neurophysiological features of ictal and interictal EEG findings: direct current shifts and high-frequency oscillations. The current technological developments have enabled us to record a wide band of EEG abnormalities, from infraslow to high-frequency activities. The ictal DC shifts are slow activities, less than 1 Hz, typically surface negative in polarity, although rarely surface positivities can be seen. Their onsets often coincide with an electrodecrement pattern in the EEG recorded with subdural electrodes. The ECOG must be recorded in settings with very low high-pass filters, 0.16 Hz or less for ictal DC shifts, with a sampling rate of 1,000 to 2,000 Hz for HFOs. Both ictal DC shifts and interictal/ictal HFOs have been reported as surrogate markers for epileptogenicity. The observation that outcomes are less favorable in patients undergoing invasive evaluations is most likely explained by the fact that these patients are selected based on their poor concordance of data. Surgical resection guided by mapping the irritative zone and ictal onset zones using subdural electrodes has, though, been associated with relatively good postoperative seizure-free outcomes. A slow spread of ictal patterns to adjacent electrodes on subdural recordings has been also associated with a better prognosis as compared to a relatively quick spread to non-contiguous electrodes. Direct cortical electrical stimulation has been used to localize eloquent cortex for over 50 years. The identification of eloquent cortex and its relationship to the epileptogenic zone is one of the main purposes of subdural and intracranial electrode monitoring. Cortical stimulation can elicit positive phenomena such as activation of motor movements, including tonic or clonic movements. It can also induce a negative phenomenon such as interference with functions such as language, including speech arrest, or interference with motor activities, including negative motor movements. Direct cortical electrical stimulation uses the following stimulation parameters: 50 Hz biphasic constant current stimuli with a stimulus duration of either 300 or 200 microseconds and a stimulus intensity that ranges from 1 to 15 milliamperes. The stimulation is applied to an active electrode while using a distance reference electrode in a non-eloquent cortex as a current sink. The active electrode is then switched electrode by electrode as each function is evaluated during the electrical stimulation process. Testing performed includes a variety of cognitive as well as sensory motor function depending upon the cortical stimulation region underlying each electrode. The stimulus intensity is gradually increased in steps of 1 to 2 milliamperes while carefully observing for change of functional status, as well as carefully looking at the ECOG data for the presence of after discharges, which is the present induction of abnormal epileptiform activity induced by the cortical stimulation. The results from cortical mapping can then be compared to the map obtained of the interictal and ictal abnormalities seen on the subdural grids. This then allows for a guide to the surgical resection margins. There are some areas that might be resectable still that were defined as eloquent cortex based on stimulation mapping. These areas include the anterior basal temporal language areas, primary negative motor areas, and supplementary sensory motor areas. Here now is the map of our patient who has undergone cortical stimulation mapping combined with the ictal regions of the brain. We now see a nice clear boundary of the ictal activity to those regions shown here in yellow where speech arrest was induced by cortical stimulation. In black are the stimulated electrodes where no function was defined, and here in red we see a face motor response when stimulating the areas of the precentral gyrus. The resulting map allows us to visualize the lesion that was noted on MRI scan and the ictal onset regions along with the functional eloquent cortex. Notice how the ictal onsets are appearing on the margin of the epileptic lesion that was defined solely on MRI scan. Regarding safety and complication of the subdural electrodes, one of the main concerns for risks of undertaking a subdural evaluation is that it may not at the end lead to any surgical options available to the patient. If the ictal onsets are seen on the edge of the strips or grids, or if the ictal onset is seen diffusely, the true onset regions would still remain undefined. This could then result in a decision to either implant more electrodes or remove the electrodes without a surgical option being given to the patient. Other relatively common adverse events that are seen include fever, headache, and nausea. The increase in complication rates are associated with the greater number of electrodes, longer duration of monitoring, older age of the patient, left-sided grid implantation, the use of burr holes in addition to craniotomy, and the surgical experience. There are a number of research applications for subdural electrodes. The use of subdural electrodes provides a unique access to the human brain in a living patient. A number of cognitive neuroscientists have used subdural electrodes to study various large-scale networks. There are a number of different protocols that use either cognitive tasks or perturbation experiments with directed electrical cortical stimulation. One example is cortical-cortical evoked potentials. Cortical-cortical evoked potentials is a methodology for investigating long cortical-cortical pathways by recording responses that are evoked from a single pulse electrical stimulation. CSEPs, as it's known, can be used to evaluate connections between multiple different regions of the brain involving language, motor, and other functional networks in the brain. CSEPs can also be used to help study other pathological connectivities seen in the epileptic cortex. The CSEPs methodology has been adopted now by many epilepsy centers investigating a number of functional and pathological brain networks. Here's an example of the CSEP response when stimulating Broca's area. A bipolar stimulation of Broca's area results in a long cortical-cortical evoked response over the lateral aspects of the temporal lobe. Here, these responses overlap the areas where direct cortical stimulation provided a speech disruption and defining Wernicke's region. In conclusion, recording of brain electrical activity with subdural electrodes continues to play an important role in the localization of the epileptogenic focus in many patients who are candidates for epilepsy surgery. Subdural electrodes are especially useful for recording in the neocortical epilepsies to localize epileptic activity and functionally map eloquent regions of brain. As with other forms of intracranial EEG recordings, subdural recordings only cover a limited area of the brain. We now have various options for intracranial recordings: subdural electrodes, depth electrodes, or the SEEG methodology. Each needs to consider the best methodology for a patient based on their epilepsy type and the importance of functional brain mapping in that patient.